This is the second part of the presentation about environmental epidemiology, and it's not focused on the main definitions or equations that are important. It's focused on what we really hope to understand from our environmental epidemiology applications in environmental health. So I'm going to introduce some key terms about the epidemiologic triangle, how it fits in with environmental health, and then we'll focus on how we understand causality with respect to environmental epidemiology and health. When we look at this triangle, this focuses on three components: host, agent, and the environment. This triangle is used for describing causality of infectious diseases, but it can also be applied to other types of environmental problems. It's an important framework. The term environment in the triangle focuses on the domain in which disease-causing agents, like infectious microorganisms or chemicals, exist, survive, or originate external to the human host. So we could think about two examples, like the water habitat for mosquitoes in a malaria endemic setting, or we could think about air pollution in an urban environment. The host is the person or living animal that is susceptible to the agent, let's say an infectious disease or a chemical. In this case, it might be a pregnant woman susceptible to malaria, or a young child exposed to air pollution in the city. And the agent is the factor, such as a microorganism or a substance, whose presence is excessive or causes disease. In this case, we might go ahead back to the example of the malaria parasite being present in the environment, being able to be transmitted to a pregnant woman, or we could think about the chemical pollutant that's released into the environment from fuel combustion of cars. When we do environmental epidemiology in environmental health, one of the main goals we would like is to understand what environmental factors cause disease, where exposure to agent A causes disease B. However, it's very important that we define how we understand causal association. And in epidemiology, there's been a series of discussions about this. It's very complicated, but one of the things that has been used are a series of criteria called Hill's causal criteria. Hill was a Surgeon General. He was looking at relationships between exposures and outcomes, and was intending to identify things we could use to evaluate if an exposure was causing a disease. There are a lot of criteria in his suggestions, but I will just highlight a couple of them. Strength is the association and the magnitude of the association with the exposure and the outcome. In this case, we might be talking about a measure of association like an odds ratio or a risk ratio. And the farther it is away from 1 in either direction, greater or lower than 1, the stronger the evidence that this exposure is causing the outcome. Biologic gradient is really referring to a response to increasing exposure, meaning increased outcome, or a dose response. So we might consider that evidence suggesting that higher pollutant levels cause more disease is a strong indicator that this pollution causes the outcome. There are a number of other criteria that I suggest that you read and review to understand them fully, but it's important to have something to evaluate how strong is the evidence that this exposure causes the disease, because sometimes it's just that they're in the same place at the same time. Important to all of our work in environmental epidemiology, relevant to the type of study design, to the evidence that we review, is understanding the role of bias. And bias is the deviation from the truth. There are many reasons why bias can lead us to draw the wrong conclusions in environmental epidemiology. It may be the design of a study, the interpretation of the data, and the drawing of conclusions. And there are some great examples of how study design can lead us to draw wrong conclusions. But I'll highlight 3 examples of bias in epidemiology that apply to environmental epidemiology. One is the healthy worker effect. And this is the observation that people employed tend to have a lower mortality experience than the general population. In this case, if we were studying an exposure focused on people employed, even in a specific hazardous industry setting, we might underestimate the impact of the exposure on the general population. The healthy worker effect could also introduce selection bias into studies about occupational mortality. This is just one example of a type of bias that could occur as a result of a study design and a selection of the population. Confounding, which is a term that should be familiar to you if you've taken a class in epidemiology, is the distortion of a measure of effect of an exposure on an outcome. So what happens is that there are other factors that influence the outcome that are also associated with the exposure. When that happens, we may inadvertently interpret the association between the main exposure and the outcome incorrectly. There are many limitations of epidemiologic studies, particularly around chronic disease like diabetes or non-communicable disease like cancer. With those diseases, there may be very long latency periods that is hard to link the environmental exposure to the outcome because the outcome happens decades later. Often the diseases that we're talking about that have significant impact but may be very infrequent in the population are difficult to measure. There are very few cases of cancer. While it's still a major killer, it's still low incidence and prevalence throughout the population. It can be difficult to measure exposures. How do I measure your exposure to air pollution? And many times, it's very hard to identify the specific effects of the exposure. It can be non-specific to the certain exposure. There are many health outcomes associated with different exposures. This is a table basically describing some of the challenges that epidemiologists face examining exposures in environmental community, pollution, and health outcomes. In detecting the disease, as I mentioned, sometimes it takes decades for the disease to occur. Sometimes there's clinical features that are not specific to any disease, small population size and low frequency, and then observational bias in reporting the illness. In trying to measure the exposure, it may be difficult to measure. We may have to use a non-direct measure or an indirect measure of the exposure, like distance to a solid waste landfill. There's uncertainty in how the exposure leads to the illness, and most settings are very often low concentration exposures. So we don't have useful dose response data. While there are weaknesses, it's important to understand that there are important strengths in applying environmental epidemiology and environmental health. The main strengths are that we often engage in real-world problems and produce action for reducing exposures, improving health, and making overall improvements for populations.